Okay, so the purpose of this chapter is to basically give you basic information on respiratory emergencies, on how to assess them, and how to treat them at a basic level. We are going to go over the anatomy of the upper airway and the lower airway. We're going to talk about signs and symptoms and how to treat respiratory emergencies. We're also going to talk about some specific conditions and injuries and talk about the pathophysiology and management of those conditions and injuries. Dyspnea is a pretty common complaint. Dyspnea means difficulty in breathing, and there's many reasons that a person might feel short of breath or have dyspnea, from an easy common cold, hay fever, pulmonary edema, which is fluid filling the lungs, congestive heart failure, an asthma attack, or COPD exacerbation. All of these conditions can cause someone to be short of breath. And many times we don't know why they're short of breath while we're treating them, but we treat some of the symptoms and signs and we're able to make a difference in someone's condition. All right, this slide shows us some of the anatomy of the respiratory system, and the chapter on anatomy and physiology that you had earlier in the book goes over this in greater detail. But basically, all of the anatomy and structures that are used in our respiratory cycle, from the brain, the nerves, the diaphragm, the nerves that innervate the diaphragm, the chest wall muscles, the intercostal muscles, and that help us breathe as well as with the diaphragm. All of those things help us breathe in and out. Okay, all of the upper airway consists of all the structures above the level of the larynx. So everything above the vocal cords. And basically air enters the upper airway, and the function of a lot of the upper airway is to warm and humidify the air as it goes down farther. So the next slide will go a little bit more on some of those structures right there at the larynx. Okay, this picture is showing you a basically diagram of the respiratory system, and I was going to point out the epiglottis here, and the purpose of the epiglottis it's a leaf-shaped structure of cartilage that drops over the glottic opening there when we swallow, so that food and water don't get down into our trachea. So we have the oral pharynx down here by the mouth, the back of the nasopharynx behind the nose, and they call kind of below the mouth the hypopharynx. Then that opens up into your larynx and your vocal cords there. And then the trachea branches off into the right and left mainstem bronchi. And then it goes smaller and smaller through bronchioles and small till you see the alveoli here. So that's how the anatomy of the respiratory system kind of is, and the function of our respiratory system ask yourself that question. What is the function of our respiratory system? What do we do? Why do we need to breathe? Kind of things. And the main function of a respiratory system is to diffuse oxygen and carbon dioxide, and then our oxygen attaches to our red blood cell on the heme. The hemoglobin has 4 receptors for our oxygen molecules, and that is delivered to our tissues and organs where it's needed. Carbon dioxide is diffused over into our alveoli, and then we breathe that out. So it is all about the oxygen and carbon dioxide diffusion. And we're going to go more into that in just a moment. Okay, as we were saying, the principal function of the lungs is to exchange that oxygen and carbon dioxide. And in a healthy adult or a healthy person, this happens very quickly and there's no problems. And that what happens, as you know from your airway management chapter 10, is that it's all about that gradient. So oxygen will diffuse from higher concentration to lower concentration, as well as carbon dioxide doing the same thing. And then we have that exchange both at the alveolar level and that exchange at the organ and tissue and cellular level. At the alveolar level, if you recall, that's called external respiration, and in the tissues, cells, organs, that's called internal respiration. And it has everything to do about that oxygen and carbon dioxide, basically concentration gradient. Okay, and we've already mentioned this, but the 2 processes of inspiration and expiration as we inhale and exhale. The oxygen and carbon dioxide diffuses based on that concentration gradient. From a higher level, it diffuses over to a lower level. And how fast and how deeply we breathe is all controlled by the brain. And we're going to talk about that in a second. Let's look at the pictures that on the next slide where this internal and external respiration happens. Okay, this first picture here is showing you that external respiration. Number 1, the deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries and arterioles. And then number 2, gas exchange takes place at the capillary covering alveoli, and the oxygenated blood is carried from the lungs to the heart by the pulmonary veins and venules, and then transported to where it needs to go. So this would be external respiration. Okay. Now this picture here is showing you the capillaries where the oxygenated blood and the carbon dioxide, as you know, as the cells do their thing and metabolize, they produce carbon dioxide. That is a normal function of cellular metabolism. And so here it's showing you the red blood cells here at the capillary level, and the cells here, the oxygen and carbon dioxide gradient. The oxygen gradient is there's more oxygen on the red blood cell here at the cellular level here, and this is internal respiration here, so internal, and it's showing you the oxygen going into the cells and the carbon dioxide going out of the cells. So at the alveolar level, we have external respiration, and at the cellular level, we have that internal respiration. Okay, we've talked enough about the oxygen passing into the alveoli and passing into the cells already. So let's talk about this second part. Brainstem senses blood's carbon dioxide levels. So in our body likes homeostasis, and we like to have our pH level at 7.35 to 7.45. In addition, our carbon dioxide level, we like to have 3.5 to 4.5. It's pretty easy to remember these because the 3.5 and the 4.5 are the same numbers. But the brainstem regulates our rate of respiration based on our carbon dioxide levels. So if our carbon dioxide levels fall below 35, because we're breathing out carbon dioxide, our brain tells our respiratory center to slow down so that we kind of blow out less carbon dioxide and we're able to get back into this level. Conversely, if our carbon dioxide levels have increased, our brain senses that increased carbon dioxide and tells our body to breathe faster so that we're able to once again get into our normal levels of that 3.5 and 4.5. So carbon dioxide is pretty important, not only in diffusion of that waste product that it is, but also to help us breathe at a normal rate and depth. So there's that. Okay, if you look at the title of this slide, pathophysiology, and I know you've gone over pathophysiology of different things, but patho is disease, and ology is the study of, and physio would be our systems, processes. So this pathophysiology is the study when things are not working right. Basically, disease processes or conditions or something that is hindering the normal body functions. So in this slide, they're talking about oxygen exchange problems. So pathological or abnormal things that can cause problems with our oxygenation, our normal respiration, can be things like the problems with anatomy of the airway. Maybe there's a lot of swelling in the tissue, in the tongue, or the epiglottis swells shut over the trachea. That would be a bad thing. Any disease processes, COPD, congestive heart failure, asthma, traumatic conditions like you get hit in the chest with something, break some ribs, can cause damage to the lung itself, the tissue, the parenchyma, or rib fractures cause a lot of pain when you breathe, and so we tend to breathe very, very shallow, which doesn't help with our breathing process at all. And then damage or problems with our pulmonary vessels themselves that transport that oxygen, back and forth from the heart and to the heart can have a problem. So how about the capillary bed surrounding the alveoli? Okay, sorry about that. So recognizing the signs and symptoms of inadequate breathing and know how to treat patients with inadequate breathing. In order to kind of figure out who has inadequate breathing, you need to recognize what adequate breathing is. So in your book on 588, table 15-2, it gives you signs and symptoms of inadequate breathing. And I want you to look at that list, take a break, put this on pause, look at that list, and understand that quickly recognizing someone who is having inadequate breathing and trying to fix that problem for them can mean the difference sometimes of someone progressing to respiratory failure and needing to be intubated. So sometimes we work rather quickly when someone is right on that precipice of just difficulty breathing and dyspnea and almost into respiratory failure. Sometimes by the time we get there, by the time they actually call, they are already in respiratory failure, and we're making the decision rapidly to paralyze them, sedate them, and intubate them. So that is super important to recognize those signs of inadequate breathing. And some of the main ones that we look at are their mentation. So are they altered now? And if the patient is not altered all the time, it's really easy for us to say, hey, is this their baseline? No, they talk and communicate and all that sort of stuff. So that's super important. So knowing what their baseline mental status is and if it's gotten worse. They use accessory muscles to breathe. So they're above their clavicles, supraclavicular muscles there. They're using those. They're pursing their lips. They're using their belly to breathe. Their intercostal muscles start to retract in. It's easy to see that on thinner people more than large people. But if they're tripoding, can't speak in more than 1 or 2 words before they have to gasp for breath, when they get up to move, they get really, really short of breath, and to the point sometimes where they stop breathing altogether. Listen to their lung sounds. So listening to lung sounds is much easier to do on the posterior back because there's not as much tissue as on the front, you know. But a lot of people can't even lean forward. That's how dyspneic they are and short of breath they are. Just that motion wears them out. So we kind of listen to where we can. So on the front, underneath the clavicles, on both sides, and then I like to listen underneath the armpit on both sides. And sometimes if I can't get there because they're too big, you know, I'll just listen on both sides of their sternum, about the 4th or 5th intercostal space down. It's hard to show you, so I'm gonna turn on the video for just a minute. Okay, now I gotta sit up though, because I'm in my bedroom at work. So let me try to turn this on. Hello. Well, it's been on, right? Well, we're going to find in your book, I think, a picture about where to listen, either on the back or on the front. So stand by. Let me pause it. Let me see if I can get it to work. Okay, well, I can get the camera to work, but I will find a picture and point it out to you. Now, this last bullet here, the second bullet, is talking about the hypoxic drive. So end-stage chronic obstructive pulmonary disease, people who have chronic bronchitis or chronic emphysema or combination of both. End-stage COPD So as they have a problem with exhaling their carbon dioxide, and they tend to retain more carbon dioxide, more so than that, if you recall the normals, that carbon dioxide is 35 to 45. So they kind of chronically are hypercapnic or hypercarbic, okay, in their bloodstream. They have more around that 45 and higher level of carbon dioxide. Well, they can't, their body has to get used to that, and the reason being is they can't sustain breathing 30 times a minute for the rest of their life. You know, it's not feasible as far as workload on the muscles and that help us breathe and all. So their body kind of gets used to that high CO2 retention a little bit. And because of that, they don't breathe fast based on that carbon dioxide. Well, what they go to is called the hypoxic drive. And so what drives end-stage chronic COPDers is low levels or high levels of oxygen. So if they have high levels of oxygen in their bloodstream, they'll breathe slower. And if they have lower levels of oxygen, they breathe a little bit faster and deeper. So if we give high flow oxygen to an end-stage chronic COPDer, we might stop them breathing because their body's like, oh, we have enough oxygen, I don't need to breathe, we're good. Well, we kind of all need to breathe. So, but it takes hours and hours and sometimes days of high flow oxygen to shut down their respiratory drive altogether. And even if we did, the thing that we would need to do is to use a bag valve mask and ventilate them. So really we can fix the problem if we did that. And we never, ever, ever withhold oxygen from someone who needs it. Doesn't matter if they're end-stage COPD. I might not be shooting for 99 or 100% on their oxygen sat. They might sit normally around 91, 92, and that's fine. And I'll ask them, hey, what do your oxygen saturations sit around normally? And they'll say, oh, 89, 90 is my normal. Okay, so that's what I'm going to shoot for. So those concepts are important to realize, but we never, ever withhold oxygen from someone who needs it. Now, some of the causes of dyspnea, which we're going to go into each one at a time, so I'm just going to go down the list. And I already had mentioned that sometimes the level of hypoxia and dyspnea cause an altered mental status, and that is a big issue. So pulmonary edema, hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental industrial exposures, like to caustic or poisonous gases and stuff, drug overdoses, and then we'll continue on to the next slide. Okay, some causes of dyspnea, and understand that a patient can have chronic issues and then acute issues on top of the chronic issues, or they can have more than one thing going on. So dyspneic patients can have gas exchange obstructions. So this is when the gas exchange from the alveoli and the pulmonary circulation is obstructed. So it can be fluid, pulmonary edema, it can be an infection like pneumonia can cause that, or just plain the alveoli is collapsed, and that's called atelectasis, damaged alveoli. So in chronic emphysema patients, COPD patients, their alveoli are actually damaged. So from smoke inhalation or whatever has caused their emphysema, they have damaged alveoli and they cannot participate in that oxygen CO2 diffusion process because they're so damaged. Obstructed airway passages. So airway passages are obstructed by mucus, like COPD. They produce mucus. Asthma, they produce mucus as well. Floppy airways. So if they're relaxed and they have an obstruction, maybe by their tongue, or the epiglottis swells from epiglottitis, or chemical inhalation, or superheated air inhalation that's like a inhalation injury in space that's can cause swelling. Even muscle spasms, or when somebody is seizing, their diaphragm and intercostal muscles are not working, and so they're not breathing during that seizure. So obstructed blood flow to the lungs, this is where we're talking about a pulmonary emboli, where a clot has broken off from somewhere else and traveled up and lodged in the circulation, the pulmonary circulation. Well, everything that's downflow from that obstruction is not getting perfusion, and therefore no blood flow is flowing, so therefore oxygen and carbon dioxide are not going to exchange. And then the pleural space being filled with excess fluid. This is like from pulmonary edema, or from pus, or just fluid that has accumulated in there that can cause the air exchange not to happen. We already discussed some of the signs and symptoms that you're going to see with inadequate breathing. So look at that table again, 15-2. Okay, patients who have like asthma situations, they quite often talk about tightness in their chest, and some people have chest pain. So it's very important when you're talking to someone complaining of shortness of breath or dyspnea to ask about chest pain, as well as it's super important to ask people who are having chest pain if they're having any shortness of breath. So some of the things that you're going to see, like congestive heart failure, possibly a pulmonary emboli, pneumonia can cause pain. So, myocardial infarction can be a problem, and they can feel a little short of breath with that as well. So, like we talked about getting hit in the chest with something, or breaking some ribs and causing people to breathe really shallow and fast, because it hurts if they take a deep breath. So some of the causes of dyspnea are from those issues. So always ask about chest pain and shortness of breath, kind of almost at the same time with a patient with chest pain or a patient with dyspnea. Okay, let's talk about problems with infectious diseases that can cause problems with our oxygenation. So infections can cause swelling. Infections can cause increased mucus production, as well as upper airway obstruction, croup. Those kind of things can cause problems with oxygenation. So we're going to talk about some of these upper and lower airway infections in the next few slides. Okay, let's talk about croup first. Croup basically is swelling and inflammation in the pharynx, larynx, and trachea, and that soft tissue there. It's quite frequently seen in little kiddos 6 months to about 3 years. It usually peaks in late fall and winter. Will have a lot of croup calls in that time. And if you've ever had kids, you kind of probably have dealt with this. The progression usually is they have upper respiratory symptoms, a cold, runny nose, sore throat for a couple days, low grade fever, and then at night they get worse and that swelling gets worse, and you'll hear that seal-like bark cough, ooh, ooh, like that. And that is kind of a croupy sound there. A lot of times it gets better if you put them in like the bathroom, put the hot shower on, let the hot humidity kind of stay in there for a few minutes, let them breathe that in, and then go outside in the cold, and that cold will kind of make that swelling decrease there. So a lot of times in the house they'll be croupy, and by the time we get them outside in the cold and stuff, that croupy cough will kind of be lessened. So cold humidified oxygen is a good thing with croup. And we don't give them bronchodilators like we give asthma folks, because that can make it worse. It's not a wheezing, it's a swelling right here at their larynx. Kids have narrower airways than adults, of course, because they're smaller, and so a little bit of swelling around that soft tissue around the pharynx and the larynx causes, obstruction in airflow. So that's what you're hearing when they cough. Okay, let's break this word down, epiglottitis. The itis is swelling, and then you have the root word, which is epiglottis. So this epiglottitis is swelling of the epiglottis. Now, in kids, it usually, just think about their epiglottis. It's smaller than ours, but it is shaped differently than in adults. They have typically kind of like an omega, this is bad, shaped epiglottis like this, and that's all soft, cartilage. And then say it swells, any part of it just swells, that could potentially swell over the trachea. So it is a serious problem. It's usually caused by a bacteria, and it's usually pretty quick onset. They'll have a high fever, sore throat, and then as that epiglottis swells, they will sit in tripod position. Just because they can't swallow, they'll be drooling and head forward, in sniffing position. And if we stick anything like a tongue blade to look at their throat in their mouth, it might cause that epiglottis to completely shut. So we don't do that. Now, like I said, it's typically in infants and children. However, I have seen epiglottitis in adults, and it's just less common. There's a vaccine that we get as kids that has reduced the incidence of epiglottitis. I haven't seen it for a long time, so that's a good thing. But just be careful. Let them position themselves. Don't aggravate them. Don't let them cry. Don't stick anything in their mouth. Give them oxygen, like blow by, maybe put a mask, and don't put it on their face because it'll make them cry sometimes because they're afraid. But just kind of let the mom hold it near their face so they're getting some. And just remember to get them to the ER. I would call paramedic backup if I suspected epiglottitis, just because if that epiglottis completely shuts, a paramedic can do a more, cricothyrotomy or needle crike, where they're putting either a surgical incision or depending on the age of the kiddo, putting a needle in their trachea and basically breathing through that. So just remember that stuff. Before I get into RSV, I didn't mention, like I should have, if you are kind of seeing a theme here, these infections, it's viral or bacterial or both. It's very, very important to use universal precautions if you suspect anyone with some sort of an infection. So proper hand hygiene, meaning you wash your hands for at least 20 to 30 seconds after every patient contact. You're changing your gloves. You wear a mask, and sometimes that will be a procedure mask, and sometimes that will be a N95 mask, and eyewear, so goggles or eyewear protection. And sometimes it means we put a gown on, especially right now with the coronavirus, with the SARS-CoV-2 infection or issue. We're having to wear procedure masks in the stations to keep each other from getting sick from us. Also, every patient contact that we have, we're wearing N95 and goggles and gloves. If we have a possible COVID patient, a person under investigation, then we add a gown to that stuff, and then as well as if it's a COVID positive, we'll have a gown, gloves, eyewear, and N95 or PAPR device. So it is super, super important. Hand hygiene, don't touch your face. You've seen commercials about it, but just thinking about the spread of viruses and bacterial infections, we could be spreading it. So we have to protect ourselves. We have to protect people around us, and especially someone with a compromised immune system. Okay, so RSV is a fairly common and unfortunate diagnosis for kiddos. Usually happens in kids that have been born prematurely, or they just their immune system just isn't what it needs to be. So what usually happens is they have low oxygen saturations, they're a little wheezy, they could have some pneumonia, and these are all pretty serious in these kiddos with compromised immune systems, or they're very, very young and were born premature. It is pretty contagious, so you're gonna want to, it's droplet spread, just like the coronavirus. So you're going to want to have a gown on, gloves, eyewear, and a mask. Typically, just like with COVID and some of these other things, if somebody is coughing, coughs come out about 400 liters per minute. Just spread, just shoot out, and it can shoot out for pretty far. And that's why you hear a lot about the social distancing right now, because of the cough problems. I'm sorry. So it's super important to protect yourself when you think somebody might be infected, even with RSV. Humidified oxygen is good. We tend to just kind of position these little kiddos, take their temperature, we'll try to suction their nose and mouth a little bit sometimes, and that oxygen, that humidified oxygen helps get them to the hospital. Okay, let's look at this word as well. So bronchiolitis, remember itis is inflammation, and bronchioles, that would be inflammation of the bronchioles. So this is usually a viral illness. It is associated frequently with the RSV, and usually in little newborns and toddlers. And this is where they'll have swelling of the bronchioles as well as mucus production, kind of like an asthma almost. And they'll wheeze and have increased mucus, and a lot of them need to be hospitalized. So we frequently see them. We'll give them some blow-by oxygen, kind of support them, and get them to the hospital. Pay particular attention because it's interesting. A lot of these kiddos that were diagnosed with bronchiolitis go on later, when they're older, to develop asthma. So it's a very interesting progression. Okay, let's talk about pneumonia. Now, pneumonia is a pretty significant or high morbidity, which means people die worldwide. Older people and younger kids die of pneumonia, and it basically just means an infection in the lungs. So, and a pneumonia can be viral or it can be bacterial. Bacterial seems to come on onset quicker. They usually have high fevers and profound hypoxia. They just feel really bad. It's called general malaise, where their whole body hurts, they're weak, they're lethargic, those kind of things. And when that infection kind of it just collects in the lung tissue, the easiest place to get a pneumonia, like an aspiration pneumonia from maybe not older people that have had strokes or something, they're not able to swallow as well, they have dysphagia. That would be DYS. Here, I'll spell it on this. So this dysphagia is spelled this way, because there's another kind of dysphagia. This is the inability to swallow well, and then this dysphagia with an SIA is when like when a stroke happens and they can't speak properly, so you'll hear some slurring or the inability to speak at all. So this is the one that I'm talking about. So they're not able to swallow appropriately, and say they're drinking some water or trying to swallow some food and it goes down into their trachea instead of just in their esophagus, and they can get aspiration pneumonia. The easiest path, if you remember in your anatomy, for those lungs, as it goes down your trachea and then branches off into your right and left bronchi. So the right one has less of an angle, where the left one kind of has more of an angle, and so it tends to an aspiration pneumonia or something tends to be on the right side. Now, not always, and it can be on both sides, but that is an interesting fun fact, I guess. So things like being in nursing homes around, or even a prison where you're around people all the time, germs and viruses and bacteria, they propagate, and they are very contagious, and so that predisposes people to a pneumonia. Recent hospitalizations can, because there's tons of germs. Everybody doesn't want to think about it, but there are. It's a pretty messy place. Anyone with chronic diseases that already put them at risk for anything, like a new infection can predispose them. If they have, if they're immune compromised, so people on chemotherapy, um, people that have like HIV, their immune system is suppressed and they're more likely to have infections. Any fever in a chemotherapy patient, any elevation of their temperature, they need to be evaluated quickly so that they can receive the proper treatment before it goes too far. Another predisposition for um, pneumonia would be somebody having chronic breathing problems, like history of COPD already. Now, symptoms of pneumonia vary from person to person. Sometimes they just, like if it's a viral thing, they just start out with upper respiratory infection, they have a sore throat, a cough, and then it progresses to they just feel, sick and that general malaise, just kind of lethargic, less apt to go run around up and down the stairs. And then it might progress into a pneumonia. So a bacterial pneumonia sometimes has an onset that's very quick. They tend to have higher fevers. They can be fine, yesterday, and then today just have profound shortness of breath. You put the pulse oximeter on them and they're like down into the 80s, 70s, or 80s. They may have cyanosis around their lips. The tip of their nose tends to get a little cyanotic. Sometimes the tips of their fingers, their earlobes. So these places you need to assess and look at to see color changes. They tend to have a fever and be hot to the touch. Be tachypnic, where their respiratory rate is over 20, and breathe shallow. They could be hot and dry, or flush even, or pale, just depends on the person. If a kiddo has a high fever, it may predispose them to some febrile seizures as well. They can have a productive cough, and just doing simple things like standing up just wear them out and increase their dyspnea or their shortness of breath, and that's called exertional dyspnea. Or their work of breathing increases. You'll see accessory muscle use, so their muscles above their clavicles and their intercostal muscles and their bellies breathing really hard. All those things can be cause of or signs of pneumonia. You'll listen to their lungs sometimes and you'll hear some wheezes, maybe some rhonchi, really coarse rhonchi, like, when you clear your throat, that rattling that you hear before you clear your throat, that's called rhonchi. Fine crackles. If you take your hair by your ear and rub it between your fingers, that is a crackly sound. And sometimes you'll hear that in the bases or middle lobes of the lungs, sometimes with pneumonia. Regardless of whether it's bacterial or viral, it doesn't matter. We just need to, first off, protect ourselves. So we'll put usually oxygen on the patient and put a procedure mask over the top of that oxygen, whether it's a nasal cannula or a non-rebreather. We need to assess their temperature and note it. We need to just maintain their airway. Sometimes they need suctioning if they're kind of lethargic and not able to swallow a lot very well. And possibly bag valve mask. Ask for paramedic support. And the paramedics, when they're there, they may choose to give them a breathing treatment. Depends on the amount of bronchoconstriction and wheezing you hear, but it typically doesn't help a pneumonia. Now, possibly a humidified air or a humidified nebulizer with just saline might work a little little bit to break some of that up, but typically not. We'll sometimes have to intubate them because they just cannot protect their airway. They're so lethargic and so altered. So that is kind of supplemental treatment of what we do. So it is important to catch those pneumonias. Okay, let's talk about pertussis. Now, when you were a kiddo and you were immunized, this is one of the bacterial infections that you're immunized against. So you don't see it a whole lot, except for now the folks that don't immunize their kids are at risk for this. You become an adult and you actually may get pertussis. It's airborne, so droplet contagious. It usually affects children under 6 and can be life-threatening in kiddos 6 months one. So it can be very, very serious. And what happens is this bacteria develops a very thick secretions in the back of the throat and down the bronchi. And when they cough and they have bad coughing fits, they'll whoop. It's called whooping cough. Whoop, whoop, like that. And that's from the obstruction of the thick, yucky stuff that's in the back of their throat. So they'll cough, 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 hack, 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 turn colors, not able to catch their breath, all that stuff. And then they'll be trying to breathe in, and because of that obstruction, whoop, they'll sound like they're whooping. So that's why it's called whooping cough. People who are at risk are, again, immunocompromised folks. And it's an infection that, I mean, it's pretty severe. People used to die from it before we had the immunization a lot. They can get pretty dehydrated and feverish, and just be so worn out from constantly coughing, not getting any sleep. They don't want to eat. So even older people who have it, like the elderly, they can even crack ribs from coughing so hard. So what we do again is we may be able to support them. We can suction some of that stuff out of their mouth if it's there. Supplemental oxygen, put a mask over a procedure mask over the top of their oxygen source. Be careful of droplet precautions, so wear your N95, a procedure mask, put on goggles or eye protection, have gloves on, and sometimes we even put gowns on so that if they are coughing, we don't get it on our clothes. That's kind of what we do for pertussis. And again, it's not very seen very much, but you can see it. So okay, let's talk about influenza. Well, we used to just say the flu, but people mostly think of the flu as stomach issues like GI, nausea, vomiting, diarrhea. When the CDC and healthcare professionals talk about influenza, they're talking about influenza A or B. Now, there are actually 4 types of influenza. Type A, type B are usually the human ones that affect humans. C can cause more mild symptoms, and influenza D pretty much affects cattle. Now, if you recall, there was an influenza A pandemic in 2009, and we called that influenza a H1N1, and it affected everyone worldwide. It was a pretty severe epidemic, or pandemic actually. Killed, hundreds of thousands of people. Now, everybody's probably had the flu before, where you feel those muscle aches, the headache, the fatigue, cough, fever, sore throat, all of that runny nose stuff. Um, that influenza can actually lead to pneumonia, dehydration. If you have chronic illnesses, especially respiratory, it tends to be more severe. Um, every year, the CDC tries to um, figure out what type of vaccine to produce, and they try to use a couple of A influenza, some B, and there's so many subtypes and all of that I think there's like 138 types of flu that they kind of have to decide what it's going to be this year. So flu epidemics or problems start to arise in the late fall and in winter. It's more deadly on the elderly and the very young. And honestly, no matter how you feel in the healthcare industry, you need to every year get a flu shot. If you don't get a flu shot, you have to wear a mask at certain times in the winter. Um, and that is usually system-wide. I mean, you usually get flu shots from your employer, and if you do get that flu, if you've had the flu shot, it won't be as severe, and so it's important to vaccinate yourself against that flu. Now, nobody likes to be sick, so that's kind of why we don't want to be somebody that infects an older person and then they die. So influenza, A and B. B is usually less severe than A, but they both can be pretty debilitating. Alright, let's talk about tuberculosis. Now, this is a bacterial infection. It's caused by Mycobacterium tuberculosis. That's a pretty big word, so we say TB a lot. But this infection affects the lungs or any organ, your meninges, your kidneys. It can infect any organ, but normally affects the lungs. This infection can be dormant for years, and it's not contagious unless it becomes active and they start to cough and aerosolize those droplets and somebody inhales that. It's pretty contagious. This usually, if it is dormant in someone, if their immune system becomes compromised for any reason, that is when it will take over. Patients often complain of this fever, this bad cough, especially at night sweats, fatigue, that general malaise, and weight loss. And these night sweats are pretty indicative of tuberculosis. Now, it is aerosolized from coughing and stuff, so as soon as you hear someone coughing, we put a procedure mask on them, and we also have N95 masks on us so that we are protected. We don't want to get infection from aerosolized stuff, viruses, bacteria, or anything. You'll usually get an annual TB test where they put that little circular wheel. They inject that underneath your skin, and they can do it through a blood test as well, but they'll recheck it after a few days. So please just understand, especially now with all these contagious things going around, COVID, we have to protect ourselves. We can't get sick. We can't infect others. So our normal PPE now when we go into calls is an N95, goggles, gloves, and if we suspect aerosolized infection or contagious stuff, we put on a gown as well. So that's our normal life now. Okay, we're going to talk a little bit about the heart to talk about pulmonary edema. So I've drawn a heart here, and on the left side of the heart, we have blood coming from the pulmonary veins back into the left atrium. Now, then it goes into the left ventricle and gets pumped out through the aorta. Now, if the left ventricle or left aorta, left atrium is damaged, maybe from a cardiac infarction or some sort of heart disease, it isn't going to pump as effectively. So if it doesn't pump out all the blood that just returned from the lungs, it's going to back up, and it's going to back up into the lung itself, and this would be left heart failure. So I always think of it as left heart failure is lung, okay, left lung. Right heart failure, when we have right heart failure, the fluid comes from the inferior and superior vena cava and goes into the right atrium. Now, when the right side of the heart is damaged, it backs up into the systemic circulation. So you'll get jugular venous distension, you'll get pedal edema possibly in their gut, and so that would be a right heart failure. I'm just going to do this. So if fluid builds up from left heart failure into the lungs, it will cause what's called pulmonary edema or fluid in the pulmonary system. Usually is because of congestive heart failure, and people having chronic congestive heart failure can manage usually with medications and stuff to keep the fluid down, but if they have an illness or they eat something that's too much sodium in it, then they might have a problem with increased fluid retention. So this pulmonary edema causes a problem. And the next slide, we're going to show you kind of what this fluid backing up does. Okay, so this picture is showing you, this is the normal capillary and alveolar bed there. So not a lot of fluid. The red blood cell has the oxygen molecule on it, and so it doesn't have to go through, the oxygen molecule doesn't have to go through that much space and fluid. Now, when there's fluid buildup here from this pulmonary edema, you can see the increased fluid around. So the oxygen gas has a lot more fluid and space to go through to diffuse, and so it doesn't happen as effectively, and they become hypoxic and dyspneic, short of breath. You'll hear usually some adventitious breath sounds like crackles. That will be the rails. That, you know, what I told you, the crackles, crackling the hair by your ear there, kind of sounds like that. Sometimes if it's pretty bad, they'll have foaming red sputum coming from their mouth and nose. And basically these folks feel like they're drowning, so they're anxious, maybe altered, have, you know, horrible sounding lungs, might be hypertensive. So we need to try to maintain their oxygen saturations and maintain their airway. So we'll suction, put high flow oxygen on them, and what we do is put continuous positive airway pressure or CPAP on them. So we will kind of have that pressure, continuous positive airway pressure kind of. It doesn't really do this, but it basically helps get the fluid out of the alveoli with that pressure gradient deal. So not everyone who has pulmonary edema has congestive heart failure, but it is a big cause. You can also get flash pulmonary edema from inhaling gases or heated air where it, damages the bronchioles and the alveoli. So that can cause some acute pulmonary edema as well. So that is kind of an explanation of what pulmonary edema is. Okay, a very large number of patients we see have COPD, and COPD is a very slow process when most often caused by cigarette smoking, but can be caused by just constant inhalation of toxic poisons and stuff that irritate the lining of the airway and bronchioles. So what happens is after years and years of either smoking or whatever has happened, their airways have become damaged, and so they have a lot of mucus production. You'll hear those COPD patients have this just rattly cough a lot all the time, and so they have increased mucus production, but the cilia that helps move that mucus up and out of our airways so we can, hawk up a loogie, cough the phlegm out. Those cilia are damaged. Those cells, the cilial cells there, have been damaged, and they're not moving very well. So we have a lot of bronchial mucus. Also, the tissue is inflamed, and as those airways become smaller, but they're still constricted and obstructed, it causes the alveoli to distend, and the alveoli, as they distend, the walls of the alveoli are broken down, and they distend out, and they just become like big holes in our lung tissue. Our alveoli are less elastic. Our lung tissue, the parenchyma itself, is less elastic, so they have a hard time breathing air out, exhaling. Bringing air in usually is just fine. It's getting that air out that becomes restricted and constricted. So COPD is kind of a generalized term for chronic bronchitis and emphysema. So most people have both, not usually just one, but they might have predominantly emphysema with some chronic bronchitis. Most people, have a mixture of both. So like we just said, the emphysema, it is the most common type of COPD. The alveoli and the lung tissue itself loses its elastic properties, and like we said, most COPDers have a combination of both chronic bronchitis and emphysema. Alright, so this picture is showing you a normal alveoli right here, where the alveolus and the capillary beds are close to each other, and the diffusion of gases is really, really good. Now, we have an inflamed lung and obstruction happening here. So if you can see the inflammation, the mucus production, the soft tissue here, the bronchioles kind of becoming inflamed and not looking good, then you have the mucus production in here. So it's going to air trap in your alveoli. And you can see here what happens. This dilated alveolus just kind of becomes ineffective, loses its elasticity, and eventually breaks down. So that it'll be like a big giant hole in the lung tissue itself where that alveoli was supposed to be. So that's a pretty good picture, diagramming that out. Okay, let's talk about this kind of overlap. Um, Patients usually with pulmonary edema will have the crackles, the rhonchi, the wet lung sounds, and patients usually with COPD will have those dry wheezes from the bronchoconstriction. And they can have both, um, but patients' presentation can look very similar. Now, it is pretty important to look at their past medical history, the medications that they're taking. Some folks have multiple, they have congestive heart failure as well as COPD and hypertension and diabetes and hypercholesterol and all these comorbidities and problems. Sometimes we're not able to kind of vet out exactly what's going on because they have both diseases, and we kind of end up treating the symptoms that they have um, with either bronchodilators, CPAP, nitroglycerin to help with the pulmonary edema, and we might not know until x-rays, labs, sometimes just a quieter environment to listen to their lung sounds. So that's kind of what this slide is talking about, the wet versus dry. Now, also the progression of their symptoms, usually with pulmonary edema, happens rather more quickly. In COPD, they start, have a couple of days of worsening breathing. Again, look at their medication list. If you have a lot of bronchodilators, metered dose inhalers, those kind of things, that COPD patients are most likely to have. With congestive heart failure, they might have a few of those, but most of the time they're taking some sort of Lasix or water pill, hydrochlorothiazide, something like that, that is going to help them with that fluid retention. There was a good example in your book about an 80-year-old man with shortness of breath, 45 minutes. The physical exam, his pulse and respirations are elevated. You observe pedal edema or swollen legs and feet, jugular venous distension. His lung sounds reveal wheezing. He has a history of hypertension, congestive heart failure, and myocardial infarction, but he has no history of smoking, asthma, or COPD. So this is asking you, kind of what kind of things are you thinking about? The general impression of this patient. Do you think it's more of a COPD exacerbation or a congestive heart failure exacerbation? And if you said congestive heart failure, you would be more correct. So kind of his progression, his signs and symptoms with the jugular venous distension. He is wheezing. However, we've got the pedal edema and that going on. So it would be more of a right heart failure with some irritation. And like I said, sometimes the COPDers can have wheezes and crackles at the same time in rhonchi, and sometimes CHF patients can have some wheezing as well. Okay, probably most of us have had some sort of hay fever or seasonal allergy. Some have asthma, and some people have had anaphylactic reactions. Now, all of these conditions are basically from an allergic reaction to something that we've taken in, either inhaled, like a seasonal allergy or something like that, ingested, or been injected with. And this is just an exaggerated immune response to whatever foreign object our body thinks doesn't belong there. Sometimes people can't identify what exactly they're allergic to, but sometimes the triggers are weird, like exercise-induced asthma, or when they go out into the cold, they might start wheezing. So we're going to talk a little bit more about all of these conditions now. Okay, we're first going to talk about asthma. Now, there's three things that are happening with an asthma attack. Number one, we have bronchoconstriction. Okay, so you have your bronchioles and they start to constrict. So the airway passage is smaller. Two, we have swelling of the muscle surrounding the bronchiole. So you have inflammation, I'll say. And three is you have this mucus production here. So you'll get all three of these things happening. And just imagine being able to breathe out of a tiny little coffee straw, a stir stick coffee straw. And you plug in your nose and you're breathing out of that with your mouth, and you can't get air out. It's hard for you to catch your breath. You feel really hypoxic and altered, and so those are some of the things that happen with an acute asthma exacerbation. Most people who have asthma are able to recognize those signs and symptoms that they start having. They might cough, have a weird wheezy cough, and normally they take their bronchodilator, their little meter dose inhaler that they puff on, and it helps stop that. Most asthma folks also take other medications like some steroids, sometimes longer acting bronchodilators. So they have a bunch of medications that they take to help stave off these asthma attacks. So most often asthma is a kid to like 5 to 17 years old kiddos, and sometimes they say, well, I used to have asthma, but I grew out of it. So you'll hear this characteristic wheezing from those bronchioles kind of constricting and having that airway lumen or tunnel. As a tunnel narrows, it can whistle when the wind blows through it, if you've ever heard that before. So they have this, it sounds like a pod of whales, if you've ever listened to whales in the ocean. It's kind of what it sounds like. It's like, ooh, ooh, ooh. So it's kind of strange when you listen to it on someone's chest. You put your stethoscope on someone's chest and listen to it. They have a hard time breathing that air out because everything's constricted. So they usually are able to bring air in. They just are still having a hard time exhaling that air. So you get air trapping as well. So they usually have a meter dose inhaler, nebulizers, and other medicines that I kind of mentioned. So Most basics, which you will be learning from the pharmacology lecture, will be able to um, administer the patient's meter dose inhaler, and that is best done through a spacer. They're able to get that medication into their airways where they need it a lot more effectively if they use a spacer, and we'll talk about that in the pharmacology lecture, and we'll show it to you when we're able to get back together. I kind of got ahead of myself. I do that a lot when I'm lecturing, but this shows you kind of most prevalent in children 5 to 17, produces that characteristic wheezing sound, and it can be caused by an allergic reaction to foods or allergens or severe emotional distress, exercise, cold, respiratory infections. So just ask about the progression, what their past medical history is, what their medications are, and you should be able to kind of figure this out. Okay, here we briefly talk about anaphylaxis, as well as allergic rhinitis or hay fever. Um, Everybody's probably had reactions to pollens and stuff like that, where you get, a runny nose, a sore throat, kind of a cough, sinus pressure, that sort of thing, itchy eyes. Most people handle them themselves. They take usually, some sort of over-the-counter thing, and possibly Benadryl and stuff, and life goes on. Now, an anaphylactic reaction is a true life-threatening emergency. It can produce, and I'll tell you that we have a whole chapter on allergies and anaphylaxis later on, but just a small little um, lesson about it right now. Let's look in your book on page 598, figure 15-9. This is how anaphylaxis can happen. So let's look at that B there. What happens is your body, this is an immune response, and your body has been um, sensitized to something that the body has decided is something that it should fight. So it develops these antibodies, and antibodies are specific to the specific antigen. And so if you see the Y's there on the mast cell wall, you can see that B, it's kind of a Y thing. So that's the antibody. And when the antigen is introduced into the body, like this B is stinging someone, so that antigen, those chemicals, find the antibodies. They combine with it, and what this does is changes the cell wall of that mast cell. And then chemical mediators like histamine and neutrophils and eosinophils, those kind of things, not neutrophils, but leukotrienes, prostaglandins, there we go, now my brain's working. Those are released out of the mast cell wall and cause certain things to happen in our organs. You can see the lungs here. Those chemical mediators cause bronchospasm and vasoconstriction. So here in the lungs, it's going to cause that. Now in the heart, it's going to cause some decreased output. It's going to cause some coronary artery constriction, which is not good with that muscle. In our blood vessels, it's going to cause vasodilation and leakiness, so we'll have edema. The skin, you'll have that itchiness, urticaria, edema, so it'll be itchy, that's the pruritus. Urticaria is that kind of weird raised wheel rash thing that goes on, and then from the leaky blood vessels, you'll have that edema. And this can be very, very life-threatening. Our airways can close from tissue swelling. The bronchoconstriction can be very, very severe, as well as some of the hypotension can be like drop your blood pressure into the 40s systolically. So what we do is treat it as a true emergency, and we give injections of epinephrine 1 to 10,000, or 1 to 1,000, sorry, 1 to 1,000. So the epi for IM injection for anaphylaxis is epi or epinephrine, and it's a 1 to 1,000 concentration. And we usually give, for an adult, we usually give 0.3 milligrams. And then for kiddos, I think it's less than 60 pounds, they get 0.15 or half of that adult dose, if you can see that, milligrams. Okay, so again, we have more on that. We give antihistamines, Benadryl, Solumedrol, which is a steroid, oxygen, bronchodilators, those kind of things. But the main thing that we do with an anaphylactic reaction is to give this epi. Okay, that's going to save them, not everything else that we do. Okay, spontaneous pneumothorax. Let's talk about that. Pneumothorax is the word itself. If you look at it, thorax is the chest, and pneumo is air. So this would be air accumulation in the chest, and more specifically in the pleural space. If you recall in your anatomy portion, you have these lungs, and I'm sorry, I'm not a very good artist, and there is a pleural lining on the lung and the pleural lining on the chest wall itself. So the visceral pleura is lining the lung or the organ, and then the parietal pleura lines the chest wall. So what happens in a pneumo is maybe from trauma or from some sort of high pressure or something that causes weakened areas of the lung, they have a spot where they bleb or burst. And it can be from a gunshot, for trauma. It can be from a broken rib that damages that lung. So then air is going to escape into the chest cavity, and then this lung tissue is going to get smaller and smaller because of the pressure that's building up inside the chest wall here. So the lung is actually going to collapse down. Like it says, this can happen with trauma. It can happen as spontaneous pneumo as well, where, like I said, a weakened spot in that lung tissue just blebs out or bursts. Thin, tall males who kind of grow, I think, quickly might have weakened spots in their lung tissue, and they are prime targets for spontaneous pneumo, as well as like somebody with a chronic lung disease coughing, and that incredible pressure buildup can cause problems. So listen to their lungs. They might have this symptom called pleuritic chest pain, where it hurts when they breathe in and out, hurts when you push on it. Sometimes you can hear decreased breath sounds on that side. Sometimes it's small enough that you can't hear any changes, but what they need is an x-ray. They need to figure out if that air is accumulating in that space. So it can cause a tension pneumothorax, where so much pressure has built up in this space that if you know the heart sits here, So that pressure builds up and kind of compresses that heart. So the heart can't fill, nor can it output the amount of blood needed for our body's homeostasis. So we get a decreased cardiac output, low blood pressure, and those kind of things. That's caused from a tension pneumothorax. And again, we will talk about all this in separate chapters, but this is just a basic overview of things that can cause dyspnea and shortness of breath. So management is based on supportive care, giving them oxygen, getting them to a trauma center so they can be treated and go into surgery quickly. Also, paramedics decompress tension pneumothoraxes with needles, and critical care paramedics can insert chest tubes. This is showing you an illustration of that spontaneous pneumothorax, showing you the visceral pleura on the lung itself and that parietal pleura lining the chest cavity. And that pleural space is filling with the air that's leaking from that lung. It collapses that lung down and causes problems with shortness of breath. Breath sounds may be absent on that side. So that's a good illustration. Sorry, I wrote on this slide. I can't get the eraser to erase, but let's talk about pleural effusion really quickly. This is a collection of fluid outside the lung. This compresses the lung tissue, causing that dyspnea and the shortness of breath that they might have. It can come from irritation, chemical inhalation, infection, congestive heart failure, cancer, tumors. They tend to have a sudden onset of shortness of breath, maybe some pain. If you sit them up, that fluid kind of stays in the dependent areas of the lobes and helps their feeling of dyspnea, as well as we can give them oxygen if they're hypoxic. All right, so another cause of dyspnea and shortness of breath is obstructions of the airway. So the airway needs to be patent or clear for us to be breathing right, obviously. And in an unconscious patient, the most common obstruction would be the tongue when it just relaxes and falls back into the hypopharynx. So definitely position that airway as you've learned in your lectures. Head tilt jaw, head tilt maneuver, or a jaw thrust maneuver if they have C-spine injuries. Also, if they're unconscious, you need to open that airway and see if there's any blood, teeth, vomit, anything like that. If you notice stuff coming out the side of their mouth, then definitely you need to open it up, get your suction ready, and suction anything that you see in there. And you guys learned in CPR how to clear foreign body airway obstruction, both on if it is a foreign body like food or steak or something like that, for unconscious folks as well as conscious folks. So always figure out the reason that they might be choking and clear that airway obstruction very quickly, or they cannot breathe at all. Okay, these pictures are showing you some obstructions. So in the first one, there's a piece of food stuck in his trachea, which is kind of not where it's supposed to be. It's right there in the hypopharynx, got caught probably. It's right there at probably at the epiglottis and the hypopharynx there. And the second picture is an unresponsive where their tongue is occluding that airway. So head tilt, chin lift, or jaw thrust maneuver would be great. Okay, we're going to talk about pulmonary embolism. So let's define what an embolus is. So an embolus is anything in the circulatory system that breaks off from a distant point and travels to somewhere and lodges. It can also come from the right atrium. Somebody has atrial fibrillation where their atria are not contracting normally. The blood can clot in that right atrium, and then all of a sudden the atria will kind of contract, pushing that clot out and going into the pulmonary circulation. And then it will lodge somewhere in that pulmonary system. Everything downstream from that clot will not be getting perfusion and oxygenation. That diffusion, oxygenation, and carbon dioxide, the oxygen, carbon dioxide will not be able to diffuse. So it can be completely blocked or partially blocked. These clots also, or these situations can also happen from a person that their legs are just, they're not moving, they're immobilized, lying in bed a lot, after fractures where their legs are immobilized, or surgeries, cancer, pregnancy. All these things kind of increase your situation where you may get a pulmonary embolus. So if it's large enough, if that emboli is large enough, saddle PE, it can completely shut off, kind of blood flow from the atria there on the right side of the heart. So some of the signs and symptoms you're going to see is profound dyspnea, cyanosis. They might be coughing up blood-tinged sputum, chest pain, and if you recall, the word is hemoptysis, the coughing up the blood-tinged sputum. They'll probably be tachycardic and tachypnic, so an increased heart rate and increased respiratory rate. And a lot of the times you'll find that they just say, I can't catch my breath. And, they don't have a history of COPD. They don't have any wheezing or any adventitious breath sounds at all when you auscultate their lung sounds. So ask about birth control. That increases your ability to get blood clots. Ask about any immobilization if they have been, convalescing after some sort of surgery. And then treat them. So if somebody tells you they can't catch their breath, and sometimes you put on the pulse oximeter and it's very low, sometimes you put on the pulse oximeter and it's fairly normal, and then you're looking at them and they're, air hungry, they're using accessory muscles like just to take in enough air. They're not wheezing, they're not usually having any rhonchi or crackles or anything in their lung sounds. It's just blocked, so that diffusion is not happening, and so they're not as effective at that diffusion of the oxygenation, or the oxygen and the carbon dioxide. So give them high flow oxygen if they need it, and make them comfortable, try to calm them down, and take them into the hospital rather quickly. Okay, this is giving you a visual of those signs and symptoms you might see. So dyspnea, tachycardia, tachypnea, the hypoxia, they're gonna tell you they can't catch their breath and they feel short of breath. They might be cyanotic. They might have some chest pain, and the hemoptysis. Okay, so hyperventilation is usually something that happens, can be caused by a medical condition, can be caused by anxiety and panic attacks, and sometimes it's just a little bit hard to vet out which one it is, but getting a history and trying to figure out maybe by their medication list what kind of things they're likely to have. Someone that is a diabetic and their blood glucose is very, very high, that's called hyperglycemia, if you recall. Their body is in an acidotic state, and one of the ways that we compensate for that acidosis is we breathe very fast and exhale carbon dioxide, usually called a Kussmaul respiration. I'm going to spell it here for you. So Kussmaul is a very deep and rapid respiratory pattern. So if you recall, our body likes to stay in a pH of 7.35 to 7.45. Our carbon dioxide levels like to be 35 to 45. If we're over breathing and exhaling large amounts of carbon dioxide, both our pH and our carbon dioxide are going to be affected. Now, our carbon dioxide is going to lessen if we're over breathing, and that will cause an alkalotic state. Okay, sorry, the radio was chattering. So the pH likes to be 7.35 to 7.45. Carbon dioxide likes to be 35 to 45. If we're breathing fast and over breathing and exhaling that carbon dioxide, our carbon dioxide level is going to be below 35. Now, our pH, if we're below 7.35, we're pretty acidic. If we're above 7.45, we're what's called base or alkalytic. So as we continue to overbreathe and our carbon dioxide levels go down, our pH is actually going to increase because we're blowing off our acid. Kind of think of carbon dioxide as an acid. If we're blowing it off, we're going to not have that acid anymore, and so we're going to be alkalotic. And I know that's kind of a weird situation, but just kind of think of it as whenever your carbon dioxide goes down, your pH goes up. Whenever your acid or carbon dioxide goes up, we have more acid, and we will be in an acidotic state, which would be 7.35 or less. Somebody who takes an overdose of aspirin is an acid, and if they overdose, their body's going to try to compensate for that increased acid that you've just ingested by overbreathing or hyperventilating. Sorry. In a diabetic that is hyperglycemic, in an aspirin overdoses, in some other situations, their body's trying to compensate, and so we're not going to slow them down because their body is trying to correct itself. In a panic attack or hyperventilation situation where it's just hyperventilation syndrome because their anxiety has gotten out of control, we're going to coach them in breathing slower. Some of the things that happen when you overbreathe and hyperventilate, if you've ever done it, is your mouth starts to tingle, you get kind of lightheaded, your hands and your feet start to cramp up. Those are called carpopedal spasms. and it's just not very fun, and that makes it even worse. They tend to decide that they've got feeling some chest pain, and it just cycles. So in order to calm them down and get them to breathe slower, we have to kind of take control, have them look at you, breathe with them, slow them down and count. And we're going to breathe in 1, 2, 3, 4, 5. We're going to breathe out slowly 1, 2, 3, 4, 5, so that they can physically overcome that panic that's happening inside them. I don't want anyone ever to judge someone having an anxiety or panic attack. If you've never had one, you have no right to judge. If you ever have, you understand that feeling of being out of control and not being able to control that, and just being in a sheer panic. It is scary. So have some compassion. Treat your patients with dignity and the compassion that they deserve. So I'm going to get off that soapbox now. Okay, so this is just showing you some of the symptoms that you can see, and this painful spasms here, that's called carpal pedal spasms, and they can be very painful as well. So again, take control, help them breathe slower. Try to figure out, if it's a metabolic issue, or poisoning, or whatever, the diabetic issue, so that we don't just automatically start to coach someone who needs to breathe fast and compensate for the increased acidosis in their system. Okay, another cause of dyspnea and shortness of breath can be accidental poisonings, exposures to chemicals and gases that can damage our lung tissue, can cause pulmonary edema, burns to the airway, as well as carbon monoxide, which is odorless, very toxic to our cells, and is called the silent killer, and that is the most common cause of poisoning, according to the CDC, and we need to be very careful and not put ourselves at risk. So some of the things that you can look for is if an entire family is having the same symptoms. What time of year is it? Are they, do they have gas appliances or a stove that they are burning wood or coal or something? So carbon monoxide is produced with incomplete combustion, and when it starts to get cold, we tend to start to seal up the drafts in our home. So we have a problem with that, in that the poisonous gas, that carbon monoxide, cannot leave the house and builds up. Things that you're going to see, the symptoms that you're going to see is confusion, dyspnea, tachycardia, nausea, vomiting, headache, those kind of things, kind of flu-like symptoms almost. So it's super important to, if there's more than one person in that household that's feeling this way, get the fire department in there. They have sniffers that can alert them to high levels of some toxic gases, and get the patients out. Now, if it is a toxic gas, you cannot go in without full SCBA protection. So fire department probably will have to extricate that person. Now, if you go in with headache, signs of nausea, vomiting, kind of just some confusion, that sort of thing, and you kind of start adding up things, get the patient out, extricate yourself out of that house or wherever they are. People can try to commit suicide, and a big incomplete combustion would be from possibly your exhaust in your car, so they could tube that into the front of the car and roll up the windows. You've got to be very careful when you're coming on a scene, so that scene safety is super important. How the carbon monoxide works is it binds to that hemoglobin like our oxygen does, but it has a higher affinity for that. That bond is much more strong. It's stronger. In fact, it's a little less than 300 times stronger than oxygen. So it kind of binds to that hemoglobin, and the oxygen cannot bind there. It's got that seat. So that is not good. In pretty severe cases, they'll use hyperbaric chambers and decompress that, kind of dive them down to below atmosphere and slowly raise them up, and then just high flow oxygen so that it can break that carbon monoxide bond and get that out. So be very careful and make sure that you have your head on a swivel trying to figure out what is causing these symptoms. If more than one family member is exhibiting the same signs, should be one of those things that you think about. And yeah, a whole family can have the flu at the same time, where they're just very sick all at once. But that's one thing that you need to check off your list, is that carbon monoxide poisoning. Okay, now we're going to talk about our patient assessment of someone who has difficulty breathing or the symptom of dyspnea. Now remember, your scene size up and your primary assessment are done exactly the same on every patient. You do them on every single patient. So you're going to have to practice that over and over and over. So scene safety, this PPE is super important. If they're having flu-like symptoms, fever, shortness of breath, cough, put a mask on yourself, an N95, and a procedure mask on them as soon as you get in, so that they don't cough out an infectious disease on you, like COVID or the flu or TB or something like that. Now, it is super important right now in this day and age to remember that coughing can expel those droplets that are infected at 400 liters per minute. So that is, and can go 3 feet out from them, just like a cloud. So procedure masks are used to protect you. Put it on them and it helps to block that cough. So please protect yourself. Mechanism of injury or the nature of illness. Now when we go through our points in our head, why was 911 activated? Is it flu-like symptoms? Is it fever, chills, shortness of breath, cough? Is it a whole entire family that is down, feeling short of breath, nausea, vomiting, headache? Question those around them. Try to figure that out. Finish up that scene size up with the number of patients, if you need any additional resources, and ask yourself if you need to take C-spine precautions if there was a traumatic injury involved. So your primary assessment is done, like I said, the exact same way on every single patient. You look at them, you identify any life threats that you can fix immediately. Arterial bleeding, somebody who has a blocked airway, somebody who has a huge hole in their chest, their leg is lopped off, you know, those kind of things are life threats. You need to address them as you find them. Now, forming your general impression is pretty important with a respiratory call. Note how they're sitting or standing or laying down. Note their position. Are they tripoding? Are they using accessory muscles to breathe? Are they alert? Did they look at you when you walked in? Or are they concentrating so hard on breathing that they don't really notice you? Somebody with shortness of breath and increased work of breathing, where it's taking all their concentration and all their muscles to just breathe, is not going to be needing to answer any of your questions. They can nod their head, and that's usually what I said. I'm going to ask you some questions. Just nod your head yes and no. So this is when I'm going to not ask open-ended questions. I'm going to ask yes or no questions. And if that person is just struggling to breathe, we're going to do our primary assessment, check if their airway is open, their breathing, is it labored, are they fatiguing, are they coming to the point where they're going to go into respiratory failure. So they've passed the point of having respiratory distress, and now they're tiring, they're getting lethargic, altered mental status, and soon they're going to be unresponsive, and you're going to have to be bagging them and helping them that way. So look at that. Ask others around them, how did it start, and that sort of thing. All right, so you've got your life threats identified and treated. You've looked at and decided their general impression. Are they really sick, or do they look fairly good and able to talk to you completely? Get the AVPU scale or figure out if they're oriented. Their airway, is it open and clear? Or do you hear weird sounds or adventitious sounds, stridor or wheezing, even without a stethoscope? Do you hear a cough? Get that procedure mask on. Their breathing, is their breathing rate fast, slow? Do they look like the rhythm is nice and in and out? Usually breathe in, quicker than you breathe out. It takes you a little bit longer to breathe out. So your exhalation is a little bit longer than your inhalation. So is air going in? Is it being kind of obstructed as it's coming out, and they have a very prolonged expiratory phase? Are they pursing their lips and flaring their nares, kind of trying to get that air out? COPD patients, asthma patients have a tendency to have to create that pressure to push out that air. They are doing fine at bringing air in, but when those bronchioles are constricted, when they are getting smaller and smaller, then that bronchoconstriction causes them to have problems getting air out, and they trap air inside. Are they having equal rise and fall of their chest, or does one side go up and the other go in? Is their respiratory rate too fast or too slow? Those kind of things you're looking at in their primary assessment. And then you've got your airway and your breathing. Now you're going to do a quick auscultation. If they're having problems breathing, just auscultate rather quickly. And this picture shows you some spots that you can auscultate. And I told you it's easier to auscultate from the posterior, just because they have less, fat and tissue that you have to listen through. But if they can't lean forward, if they're breathing so hard that any movement is going to cause it to get worse, then you can auscultate in front. And normally up high, you can auscultate rather easily. In women and bigger males, this spot is a little bit harder to find, and so I tend to come a little bit farther in their axillary area where they might not have so much fat tissue there. And this is if somebody is having problems breathing, I'm going to check in that breathing primary assessment part. Then I'm going to check a pulse in that primary assessment to see if it's present, fast, or slow. Now, when you're listening or auscultating for breath sounds, you're listening for adventitious or weird breath sounds. So this would be wheezing, where, like I said, I think kind of sounds like a pod of whales. And you usually hear it on exhalation. So when they're breathing, you'll put your stethoscope up, and that's what you're going to hear, that crackles or rowls. Some people call them rails, rowls, crackles. That's that fluid that's in there that the air is kind of popping through, so it sounds like crackles. Could be pulmonary edema, could be you know, an inhalation of a poisonous or toxic substance that's causing pulmonary edema. Could be from congestive heart failure. You've got to just start figuring this out. Coarse rhonchi is, you know, when you've been sick and you have that rattling in your chest and that yucky productive sputum cough, when you feel like you need to clear your throat. When you hear coarse, it's a very coarse rattle, coarse, and they can kind of be like coarse crackles, but they're going to be very coarse, as they've got that increased mucus production. And then stridor is a sign of upper respiratory inflammation, and it could be caused from croup or inhalation of a heated substance, or epiglottitis that's going to inflame that epiglottis. So that is called stridor. That's an upper respiratory obstruction. It could be caused by foreign body airway obstruction that's just partial. So stridor is upper airway. Wheezing, crackles, all those kind of things are lower airway obstructions. I get ahead of my slides sometimes. So after you've done the airway breathing, check their breath sounds quickly. You're going to evaluate for that bleeding, check their pulse rate, make sure it's present, fast, slow, irregular, and skin color, temp, and condition. And recall that in your primary assessment, you're going to actually be intervening when you see a problem. So if they need oxygen in the breathing part, give them some oxygen. If you need to stop bleeding, stop the bleeding. If you need to put a tourniquet on, put a tourniquet on. Capillary refill time in infants and children is fairly reliable, and you just blanch out their finger or even their chest or their forehead. You can blanch it out, turn white, and then it should turn pink again within 2 seconds, or it could be delayed. In adults, we kind of have circulatory issues, so it's not quite as reliable, but you can see problems, you know, just by looking at circulation and capillary refill time in adults as well. All right, so I have enough information now in my primary assessment to make a transport decision. Is this worsening? Is it a life threat? Are we going to need to start to the hospital quickly? Or is it seem like I'm able to just kind of stay and ask more questions, do a better focused history and a better secondary exam? Am I able to intervene? And maybe as a basic, you can use a metered dose inhaler, so an albuterol inhaler, or like a some rescue inhaler that they have. Or do I need to move them to the hospital quickly. Okay, after your primary assessment is done, and you've decided whether your transport decision is a rather quick one or something that we can kind of stay and do more on scene, we're going to get a set of vitals, and that will include SpO2 readings, a temperature. We're going to get a good respiratory rate, heart rate, regularity, blood pressure, and a blood glucose level. As someone is doing that, we're going to do our history taking, what I call a focused history and physical exam. So I'm going to focus on what their chief complaint is. So if they're having respiratory difficulty, I'm going to make sure that I ask questions about any chronic illnesses, COPD, congestive heart failure, what medications are you taking? What have you done to help this? Has it helped? Get your sample history, and that will help you with the medications and their past medical history. Things to guide you when you're doing your history taking. We have mnemonics. A lot of, when you started that patient assessment memorization, you remembered OPQRST, and then that's really good for pain. Well, we're going to use that to help us focus in on questions with respiratory issues too, and the next slide is going to help us do that. Also, look in your book on page 606, and we'll see how they kind of use these OPQRST questions for respiratory issues, as well as the pain one. So the O, or the onset. So when did the breathing problem start? Did it come on suddenly, or has this been going on for days? And these things are helping you figure out, is this a chronic issue? Has this been progressing, like COPD exacerbation, or a congestive heart failure issue, or an asthma issue? Is this an anaphylactic problem? Did it happen suddenly after you ate something and you do have allergies, or you may have allergies? Is this a foreign body airway obstruction? Did it happen suddenly? Were you exposed to any toxic things? So it kind of helps you figure out the onset, whether it was fast or slow. The P, what makes the breathing difficulty worse? This provocation and palliation, what makes it worse? What makes it better? If you get up and try to walk to the bathroom, do you get more short of breath? How does the breathing feel? Not the quality of pain, but how does the breathing feel? Has this happened before? Is this the worst attack that you've had? Another thing kind of with quality and severity as well is, have you ever been intubated before, hospitalized, and a tube put in your trachea, and you sedated and paralyzed, and then the machine breathes for you? So those are important things kind of to pique your index of suspicion. Radiation and region. Do you have pain anywhere? Does it move anywhere? Severity. How bad, like I was saying, is this? Is this the worst that you've had? Is this, usually when they call us like a chronic issue, they've tried to deal with it for a while, and it's become where they cannot, stop. All right, so the T is timing. Is this a continuous issue? Does it happen off and on? If it is intermittent, how frequently does it happen? So that's kind of your OPQRST when you're dealing with respiratory issues. Different from pain, but you can still use that mnemonic. You just kind of have to change your questions, because if you say, so how's your pain today? They're going to go, I don't hurt, I'm having problems breathing. So another mnemonic that we use for respiratory issues is PACE. Now, this is specific, easy to remember with difficulty breathing. So P is progression, kind of like the onset. Has it been going on? Did it come on suddenly? Or has it worsened over a couple days? And then the A is associated chest pain. Are you having any pain in your chest? Does it hurt when you breathe in? Does it hurt when I push on your chest? Because people with cardiac issues quite frequently have dyspnea or shortness of breath as well. So we're going to need to kind of ask about that. Sputum production, the S. Do you have a productive cough? What color is it? Is it yellow, green, red tinged? Those things you're going to have to ask. And then the T is talking tiredness. So how many words can they speak in a sentence? Is it one or two before they gasp for a breath, or are they able to have a really large discussion with you and not have any problems? And then exercise intolerance. So like I said before, if you walk to the bathroom, are you super short of breath? If I just have you stand up and put your rear on the bed that's sitting next to you, my gurney, is that going to increase their respiratory difficulty to the point where they're in respiratory failure? So these things you have to think of. And then you go into a secondary assessment. So with your secondary assessment, I want you to remember that head to toe format, because it's really easy to forget things, especially when you're doing a medical exam, because it's easy to do a trauma exam, a head to toe survey, and palpate everything, but you're also doing that for for medical issues as well, and I'm gonna try to help you figure that out. So look at the face. Are they having any facial drooping? Are their pupils, pinpoint? Are they dilated? Are they reactive? Look for jugular venous distension on the side of their neck. Their trachea is at midline. Go down their chest. You're going to have to look at it. You're going to have to palpate. Does it hurt when I push in? Auscultate again in more spots. So maybe in my primary assessment, I only listened to 4 areas, but now I'm going to listen to more. I'm going to see if I can set them forward and listen on their back. And you kind of just, as you saw that picture, you kind of go follow the scapula down and around on each side. Look for retractions. Look for accessory muscle use. Are their muscles above their clavicles being used to help them breathe? Is the tissue sucking in between their ribs? That's intercostal retractions. Look at their belly. Palpate their belly. See if it hurts. Sometimes in the pneumonia, their diaphragm is kind of sitting, their lung is sitting on their diaphragm, and if it has pus and crap in it, it might cause some abdominal pain. And look at their skin color. Look at their hands. Do they have, long-time smokers usually have kind of like a distal circulation issues. So you'll look at their fingers and they look a little grayish. Their fingernails kind of club over. They look, and it's just because they've had years and years of decreased circulation there. And so look at those things. Look at their feet and their legs, so you can see if they're having any pitting edema there. You have to assess your patient. You can't just, say you did. You've got to do it, or you can't write it down. So look at all those things in your secondary exam. Okay, this is showing you more things. When you've got somebody who has chronic issues like COPD, looking for these things is important. So barrel-like chest. You know, if they've been using their muscles to help them breathe, they tend to, with chronic bronchitis, have a barrel-shaped chest. So we've already talked about using accessory muscles and auscultating and stuff. Now, primary assessment that you did in your reassessment survey, you're going to do a reassessment survey by pretty much doing your primary assessment again, and then checking your interventions. Are they helping? Are things getting better or worse? So you're going to repeat your level of consciousness check, your airway, breathing, circulation check, your skin signs, that whole entire primary assessment. Redo that. Check your interventions. Is the oxygen helping? Did I use a meter dose inhaler? Is it decreasing the amount of wheezing that I hear? And just an aside here, when you auscultate someone's breath sounds and they don't have enough air movement because they're so constricted and tight that there's not a lot of air movement, you're not going to hear that wheezing. You're not going to hear hardly anything at all. So don't think it's okay because I don't hear wheezing. If you hear hardly any breath sounds moving, that should be a pucker factor, where you're going to need to be doing something or they're going to die in front of you. So put them in a position of comfort. Do they need to sit straight up? Do they need to dangle their feet a little bit if they're having a congestive heart failure, buildup of the fluid and stuff? Sometimes that helps a little bit where they can get their feet off the edge of the stretcher. Okay, some of the interventions that we can do is to administer oxygen. Some folks might benefit from continuous positive airway pressure, that CPAP. We may have to assist their respirations if they're not breathing at all, or if their breathing is totally inadequate, not deep enough. We're going to have to assist them with our bag valve mask. You should practice doing that on each other, getting a seal, clean the mask off first off. You don't want to infect each other, but and then bag someone and try to see if you can get that seal on, and kind of as they breathe in, you assist them and squeeze, and then let it go. Some patients have meter dose inhalers, the small volume nebulizers, where they have a little tiny compressor and they put medication in a little nebulizer port and then turn on the air, and it starts to nebulize or kind of fog that medication, and they're able to breathe it in. Meter dose inhaler is a metered dose of that medication every time they push that puffer. It is much better to use a meter dose inhaler with a spacer device. So if they don't have a spacer device, they're probably just kind of shooting it in their mouth and it's sticking to their cheeks and the back of their throat and stuff. So it is super important, if they have a spacer device, to coach them on how to use it. So call medical control if your protocols ask you to do that. Make sure that you have the right patient, the right medication, you're using the right dose, you've got the right expiration date, and all the rights of the patient administration of medications. And then coordinate this meter dose inhaler thing. So have them breathe deeply in and out, and then as they breathe in, slowly have them breathe in as deeply as they can. Put the spacer meter dose inhaler, have them put it in their mouth. Push that meter dose inhaler, it goes into the spacer, and then the patient slowly inhales that medication. It tends to get down into their bronchioles a lot easier and better that way. Gets down in their airways, and have them hold their breath as long as they can, and then allow them to exhale. Then put the oxygen back on and see if it's going to start to help in a couple minutes. So definitely practice that as you guys are doing your patient assessments. If we're able to have some lab time, that's a good thing to do. You guys are memorizing your medications, so your albuterol and ipratropium you are memorizing. So the indications, what kind of class it is, it's a usually a beta agonist or an anticholinergic medication, whatever cholinergic, whatever you're memorizing. So indications, get those right. Contraindications, if they're too fatigued and can't coordinate that inhalation thing. If that inhaler is not the patient's, you can't use it. Can't use her sister's medication on her. Get permission if your protocols tell you to get permission from medical control. If they've already had the maximum dose, they've already taken their prescribed dose, then you can't do anymore. If the medication is expired, that would be a contraindication. And so look at those before you give it. Most medications in this class of beta agonists dilates the bronchioles. So if they're constricting, it's going to help them open it back up, which is good. Now, you get rather nervous and anxious and shaky when you take a meter dose inhaler. So they could be pretty tachycardic, breathing a little bit fast, have some shakes in their hands and stuff. Those are very common side effects. Okay, we have 12 more slides and then the review slide, so let's get through this. And we've kind of talked about treatment as we've progressed through this, so this should be just a review. Upper and lower airway, kind of obstruction, infection, swelling, those kind of things. See how they're positioned, how they want to sit, usually upright, a little bit head forward. Administer humidified oxygen if it's that airway, that croup, or something that cold humidified oxygen is going to help. If they have secretions, suction their secretions. If you've placed an OPA in, you need to remove that before you suction. And we're going to go on. Pulmonary edema, that fluid buildup in the lungs. You're going to sit upright, provide oxygen, non-rebreather. We may have to bag them. This is a good indication for CPAP, and you can assist your partner, and you'll get to figure out how to do that and placing that on. Suction if they have any secretions in their airway, and just understand that they're going to need some of that positive pressure. And as an advanced student, you're going to learn a lot more about CPAP, some indications, the contraindications, how to apply it, but you can help your partner apply that CPAP and get it out and understand when to use it, when not to use it, and that sort of thing. Okay, COPD, they're again having problems exhaling that air out. It's not an oxygenation problem, it's a problem with hypercarbia, where they just have a lot of buildup of carbon dioxide in their blood. If they've not taken their inhaler, go ahead and help them do that properly. Sit them upright, get them going to the hospital. Don't ask them a lot of open-ended questions. They're going to be getting tired of talking in 2 to 3 word sentences. You don't want to have them tell you a story. You're going to want those yes and no answers. Okay, so asthma, kind of like COPD, we're going to possibly help them with their prescribed inhaler. We need to vet out whether this bronchoconstriction is due to an anaphylactic reaction. So, onset will help you with that. Did it happen suddenly after they got stung, or they ate something that they have allergies? Aggressive epinephrine administration if it's an anaphylactic reaction. Oxygen. Help them with their meter dose inhaler if they have that, if it is an asthma situation. If they can't break their asthma attack and start breathing right with the medication administration, it's called status asthmaticus, and it's a pretty scary feeling if you think about kind of breathing through that little coffee straw, and that's all the air you're able to get out. You're gonna have pretty scary, anxious feeling. Okay, we talked a little bit about that anaphylaxis. If it's a bee sting, scrape that stinger out. Oxygen, maintain their airway, give them epi. You guys have memorized, are memorizing your medication. So epinephrine 1 to 1,000 concentration. We're going to do IM injection. It's best to do that in the big muscle of the legs, so on their quads or laterally as well, because of the increased perfusion to that big muscle. So that'll get the medication where it needs to help quicker. Okay, is this a spontaneous pneumo? Give them oxygen, set them up, monitor that breath sounds, and watch to see if they have jugular venous distension. So is it turning into a tension pneumothorax? Pleural effusion, that fluid buildup or in the pleural cavity there. They might have to stick a syringe in there and drain it, or a chest tube or something. So provide oxygen, get them where they need to go. All right, obstructed airways, partial obstructions, we're going to kind of let them clear themselves, usually provide oxygen if we need to. If it is complete obstruction, we're going to use our Heimlich maneuvers or just CPR if they're unresponsive. Pulmonary embolism, remember, they're going to be air hungry. And so oxygen is important. They're going to be sitting up. They might have hemoptysis, so maybe suction their mouth and transport quickly. Calm them down. Try to help them breathe effectively, even though they're having a problem with their diffusion. Hyperventilation. So kind of vet out, is this hyperventilation syndrome from anxiety panic attack? Is this a symptom of a medical condition, diabetic ketoacidosis, aspirin overdose, a super bad infection where they're breathing fast? And do what you need to do. Either if it's a panic attack, help them slow down their breathing, coach them, reassure them, and if giving them a little oxygen helps them calm down, then that's fine. It's not an oxygenation problem. It's a carbon dioxide issue. So I've breathed out too much carbon dioxide. I'm alkalotic. I'm spasming and all that sort of stuff. So tell them that to kind of just relax them. All right, if there is a poisonous gas, chemical, some sort of exposure that they've had, carbon monoxide, don't become part of the problem. So that general or the scene size up is super important. Make sure that they've been decontaminated if they've been sprayed with something or whatever, and then oxygen, you know what to do. Okay, these things, we've talked about foreign body aspiration a little bit. They could have aspirate a little fluid, they'll get an aspiration pneumonia, have problems, be sick. Give them oxygen, sit them upright, and where they're gonna feel better. Now, tracheostomy dysfunction, where maybe it's swollen a little bit, or They've got a mucus plug in there. We're going to have to suction that out. And they're pretty good at figuring that out if they can, or their caregivers. So try to clear the obstruction, provide oxygen over the tracheostomy, and if they need to be evaluated, take them. Okay, we've already talked about asthma, restriction, and all that sort of stuff. So we're going to use oxygen, MDI. Cystic fibrosis, we don't see a whole lot, but occasionally they have an issue where they're not oxygenating well. And they're basically, their lungs are like fairly stiff and they're not able to diffuse. They can't breathe right. So suction, oxygenate, transport. Okay, so now we have the review questions. I think there's 10 of them. I'm gonna let you guys progress through these at your own leisure here. Try to answer the question without looking, and then make sure that you're right and figure out how you were misled or why. So these are good review questions, and I'll talk to you next time.